Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care. Peace, YouTube. Let me make sure. By Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. So, we pick up in a new chapter. Peace. YouTube, welcome. Oh, wow. Happy Sabbath. Happy Saturday, right? It's time for a new chapter. Assessment of cardiopulmonary reserves. This is episode 52, chapter 19, page 302. Acute respiratory failure is related to the severity of disease and the inadequacy of cardiopulmonary reserves. Therefore, the decision to intervene with supportive care must be based on an evaluation of the disease process in relation to the reserves of the cardiopulmonary system. The clinician must answer the question, how capable is this patient's cardiopulmonary system of maintaining adequate function while challenged by the present or anticipated physiologic stress? The respiratory care practitioner may readily assist in the assessment of cardiopulmonary reserves by evaluating three entities at a bedside. 1. Pulmonary reserve. 2. Cardiovascular reserve. And 3. Gas exchange capability. The entire scope of evaluation is listed in Table 19.1. Peace. Thank you so much for being here and reading with us. Pulmonary reserve. Ventilation is defined as the movement of gases in and out of the pulmonary tree in cyclic fashion. The purpose is to present fresh gas to alveoli for molecular exchange with pulmonary blood, followed by removal of that gas from the alveoli. This to and fro movement of gas within the pulmonary tree is reflected by spirometric pulmonary function testing. These measurements may be used to grossly estimate the efficiency of ventilation. The clinical challenge is not limited to assessment of ventilatory efficiency at the time of measurement, but also requires an assessment of the capability to maintain efficient ventilation in the presence of acute physiologic stress or disease. Thank you so much for the likes and subs. Peace, everyone. Hi, it's Heart Love. Welcome to the YouTube live book reading, the peaceful part of YouTube where we read books and learn from masters. Hi, it's Heart Love. Welcome. Happy Sabbath. Happy Saturday. Bedside evaluation of pulmonary reserve involves 1. Clinical observation of the patient's spontaneous ventilatory pattern, plus 2. Appropriate interpretation of 2 spirometric measurements, vital capacity and FEV. Yes. Force expiratory volume. Very key for these taking notes and in the playlist. Here, let's drop a pin there. Ding. All right. Bottom of page 302. The ventilatory pattern. The ventilatory pattern is composed of 1. A tidal volume, 2. A ventilatory rate, and 3. An inspiratory to expiratory ratio. Very key. All right, so table 19, 1. The assessment of cardiopulmonary reserve. This is major key. We're going to make sure we pin this. Top of page 303, where, as you'll see at the top, it says the pulmonary reserve. 1. Clinical observation. 2. Ventilatory pattern, tidal volume, rate, and inspiratory and expiratory ratio, which is C. And then 3 will be vital capacity. 4, FEV, force expiratory volume. And 5, intrapulmonary shunt. 6, dead space ventilation. And that's the pulmonary reserve. The cardiovascular reserve. 1, non-invasive. A, ECG. B, blood pressures. C, clinical observation. We're going to go through all this and I will put it in the description. So no worries. Peace, YouTube. Oh my goodness. Hi, it's Heart Love. Okay. Yes, master thyself. That's this channel. That's what this channel is for. We give information to the people so that they can master themselves, and then master yourself. You can help others around you, right? And we heal ourselves, we can help heal others. So thank you so much for being here. All right. And then 2, invasive. A, cardiac output. B, AVO2 difference. C, preload. D, afterload. And 3, contractility status. All right. And then at the bottom, it says respiration. 1, alveolar ventilation. 2, acid base. 3, oxygenation. A, arterial PO2. And B, mixed venous PO2. All right. Yeah. Oh, it's a lot, but we're going to get through all of it. Here we go. Thank you so much for reading. That's at the top of page 302. I want to make sure we get that. That's table 19.1. We are in the 19th chapter of clinical application of respiratory care by Barry A. Shapiro and Ronald A. Shapiro and Ronald A. Harrison and Carole A. Trout. Second edition, 1979. All right, so that's the assessment of the cardiopulmonary reserve. Here we go. Tidal volume is defined as the air breathed in or out of the airway during the breathing process. Measurement of tidal volume is a simple procedure described in Chapter 5. However, most clinicians fail to make the measurement because they falsely assume that they can accurately estimate air movement. It is mandatory that tidal volume measurements be carried out with critically ill patients. Although quantitative tidal volume measurement is important, the simple observation of the ease with which the patient maintains that tidal volume is equally essential. i.e., estimation of the energy being expended to breathe, is as important as the quantitative measurement itself. That's right. There we go. See, they're making it more simple because once you understand the mechanics, of the self, then you can really assess yourself, right? That's the first part of don't let anyone tell you anything else. If you're ever working with a fitness trainer, like myself, I'm a master fitness trainer. The first part is always when you're working with a client is the fitness assessment. You cannot just give anyone a prescription for certain types of exercises without doing the fitness assessment. Ding! Mhm. Measurement of tidal volume is a simple procedure described in Chapter 5. However, most clinicians fail to make the measurement because they falsely assume that they can accurately estimate air movement. It is mandatory that tidal volume, yes, measurements be carried out with critically ill patients. Although quantitative tidal volume measurement is important, the simple observation of the ease with which the patient maintains that tidal volume is equally essential. See, yeah, I had to read that again. A normal predicted tidal volume is 6 to 7 milliliters kg, 3 to 4 milliliters per pound of ideal body weight. In the average adult tidal volume of less than 300 milliliters body weight, milliliters, which would be hypopnea, or greater than 700 milliliters, which is hyperpnea, are abnormal and require further evaluation, especially when oxygen therapy is administered. See Chapter 7. We went over that. Yeah. Ventilatory rate should be counted for 1 full minute. The normal adult ventilatory rate is 12 to 18 times per minute. Ventilatory rates above normal are termed tachypnea. Rates below normal are termed bradypnea. Minute volume. MV, is the product of exhaled tidal volumes multiplied by the ventilatory rate. This calculation is important considering oxygen therapy and estimating work of breathing. The IE ratio refers to the time and relationship between inhalation and exhalation. Normally, the relationship is approximately 1 to 2, i.e., the time for exhalation is twice as long as that of inhalation. As inspiratory time may significantly affect the delivery of fresh gases to the alveoli. Expiratory time may significantly alter the degree to which the elastic lung and chest wall forces interact with airway dynamics to accomplish movement of gas out of the alveoli. Tachypnea primarily encroaches upon the expiratory time. Very key, right? It's on the expiration. Primarily encroaches upon the expiratory time. Since obstructive pulmonary disease requires longer expiratory times, Tachypnea is extremely detrimental. Irregular ventilatory patterns are abnormal and usually reflect CNS or myocardial malfunction. These may be considered forerunners for worse things to come. Very key. All right. We're at the top of page 304. Thank you for reading with us. Vital capacity. Let's do it. The interrelationship of vital capacity, ventilatory pattern, and the work of breathing were discussed in chapters 3 and 5. These principles can be summarized as follows. 1. The work of breathing is increased as the portion of the vital capacity utilized for tidal volume increases. Thus, an acutely decreased vital capacity reflects a decreased ventilatory reserve. 2. Under these conditions, the energy expended in increasing ventilatory rate is less than the energy required to increase tidal volume. The 3. The organism will choose the ventilatory pattern that produces the necessary minute ventilation at the least expenditure of energy. Bing! This is so key, right? Said it. The organism, 3 is the organism will choose the ventilatory pattern that produces the necessary minute ventilation at the least expenditure of energy. Thus, when faced with decreased ventilatory reserve, the organism generally chooses to increase the ventilatory rate and decrease the tidal volume. Thus, provides the needed minute volume for the least expenditure of energy. It's beautiful. Absolutely. Middle of page 304. Bedside assessment of ventilatory reserve is most reliably reflected in the forced vital capacity measurement. For over 20 years, forced vital capacity has been measured in critically ill patients, and the test of time has produced the following reliable guideline. A previously healthy adult requires a minimal vital capacity of 15 milliliters over kg to assure an effective cough and to adequately deep breathe. When an acutely ill patient is unable to meet this minimal vital capacity requirement, he or she must be considered limited in his or her capability to maintain an undis- undiseased pulmonary system, i.e., there exists a great likelihood for retained secretions, atelectasis, and pneumonia. Of course, a vital capacity of above 15 milliliters kg does not unequivocally guarantee the maintenance of clear lungs. Another useful guideline is that a previously healthy adult with a vital capacity acutely less than 10 milliliters kg may not be able to spontaneously maintain adequate ventilation for a prolonged period. Remember that a bedside vital capacity measurement is prone to error because both a tight airway seal and the patient's cooperation are required. With cooperative patients, the measurements may vary according to the forcefulness with which the procedure is imposed. However, all errors will give values less than the actual, since patients can never provide a vital capacity greater than their true vital capacity. Mm, mm, mm. Top of page 305. Woo! Big, right? I know. Highest heart love. It's a lot. That's what we do in this peaceful part of YouTube. We read books and learn from masters. Master thyself, heal thyself, right? It's a lot, I know. Much love. But that's what we do. Masters are always going to be mastered. Negative inspiratory force, NIF. Here we go. In patients who are unresponsive, comatose, or obtunded, the concept of negative inspiratory force was devised to estimate ventilatory reserve. The NIF maneuver has been described in Chapter 5. In normal, healthy individuals, the NIF is well in excess of negative 80 centimeters of water within 10 seconds. The NIF measurement can be clinically useful as long as its limitations are recognized and the results are not misinterpreted. Clinical experience has demonstrated that an individual who can generate a NIF of negative 20 centimeters H2O within 20 seconds can be assumed to have a vital capacity of 15 milliliters kg or greater. In other words, a negative inspiratory force of better than negative 20 centimeters H2O within 20 seconds means that the minimum vital capacity requirements for maintaining adequate ventilation over a prolonged period of time are most likely present. The measurement may be used for no more than this. Since this is a static measurement, any element of pre-existing lung disease, such as increased resistance, decreased compliance, or actual loss of lung volume, makes the measurement even more unreliable. Yeah, it's great. I know. Super high level vocab. I know. Yeah, we do it. Creating the masters of our universe. FEV, the measurement of forced expiratory volumes, has been discussed in Chapter 3. A decrease in the FEV generally reflects a significant increase in airway resistance. This is not an appropriate test for detection of early or subtle small airway disease. The very fact that this measurement reveals only significant clinical disease is its greatest asset in respiratory care. A patient with an abnormal FEV will require significant energy expenditure to increase ventilation in response to stress. The pulmonary physiologist prefers to consider FEV in terms of the patient's predicted ability to expire gas in the first second. Inspiratory, respiratory, in respiratory care, the FEV is expressed as a percentage of the patient's actual forced vital capacity. This is believed to be more reflective of the patient's reserves than are available to meet stress. A FEV over FVC of less than 50% is generally interpreted to reflect airway resistance of sufficient magnitude to significantly diminish ventilatory reserve. Yeah, yeah. That's big. That's real. Top of page 306, cardiovascular reserve. Traditionally, the cardiovascular system has been primarily supported by pharmacologic means. In spite of the technical advances of cardiac assist devices and membrane oxygenators, the application of these devices in most patients has not provided improved survival or decreased morbidity. Therefore, primary cardiovascular support in critical care still rests on pharmacology, fluid therapy, and proper acid base balance. In many circumstances, significant stabilization of cardiovascular function is accomplished by relieving the patient of the work of breathing and by augmenting his or her pulmonary gas exchange. Yeah. Oxygenation techniques and mechanical support of ventilation may often be applied primarily to aid and maintain cardiovascular function. The respiratory care practitioner must be able to evaluate the cardiovascular system, since it is impossible to support the pulmonary system appropriately without an appreciation of cardiovascular function and reserve. Often, the primary limitation to mechanical support of the pulmonary system is embarrassment of the cardiovascular system. Minimal bedside evaluation of cardiovascular reserve depends upon a clinical assessment of 1. Heart rate, 2. Blood pressure, 3. Heart as a pump, and 4. Perfusion. We'll pause right here. Continue back and then with clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Hi, it's Heart Love. Thank you so much for being here with us. Wow. New chapter. New chapter. We even got a table. All right. So when we reconvene with clinical application of respiratory care in the 19th chapter, shaking it up on YouTube, reading books, masterful books, right? We heal ourselves, we can then go and heal others, right? Can't climb mountains with a broken hip. So you gotta make sure you're healed first. We continue to go out there, spread word. You don't want to spread misinformation, right? Peace, Opak. Hi, it's Heart Love. Welcome to this peaceful part of YouTube where we read books and learn from masters. About to have a drink of love water, right? And shouts out to everyone on this peaceful day. Want to have great meditation. Shouts out to everyone. With love. All the light workers, yes. Peace, Skilla. It's Heart Love. Mm. I love you. 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 Woo! That's so good. Love water to the people. I honor you. Yeah, we're shaking it up. Happy Saturday. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Yeah, we do it. For real, for real. Super Saiyan beings. Much love. Thank you so much. Highest heart love. Yeah, we're undefeated. Champions. The light workers of this world, right? Divinely guided and protected. So nothing can stop us. You know, no one's words, no one's energy can compete. It's the highest level. That's why we read these books, right? You go down the channel. This is the peaceful part of YouTube. So I honor you. Thank you so much for being here and reading with us. Thank you for breathing with us. Highest heart. I'll see you soon. Peace, peace. Yes. Much love.